Welcome to the Social Determinants of Health, Gaps and Opportunities in the Chicago Southland. This is a recording of panel discussions with local physicians, community organizations, and government officials. The event was sponsored by the following organizations: Southland Human Services, Superior Ambulance Service, Chicago Southland Chamber of Commerce, Pathlights, and Glenwoody Golf Course. For more information about this event or future events, visit the Chicago Southland Chamber of Commerce online.
All that kind of fun stuff, but the advocacy is right at the heart of what we do, and advocacy is really what we're focusing on today. So you're going to hear a lot of great speakers. I just want to welcome everyone, but I also want to give you a little bit of the logistics of the day, because if you look at the program, you'll see we actually have 4 separate panels. And so I believe at this point now, what I want to do is bring up Paula Donohue and Elaine Grande. Elaine is a big part of this with Pathlights. They came to us with this idea, and Paula Donohue is with Ingalls, UChicago, Ingalls, but also is a Chicago Southland Chamber of Commerce board member. So I'm going to hand it off to them because they're going to facilitate the first panel. So thank you all.
So while there are many social determinants of health that are non-medical that impact our quality of life and our health, today we want to focus on access to healthcare, housing, and food. So to kick off the first panel, I'd like to introduce our health panel. Dr. Turakhia is with UChicago Medicine Ingalls Memorial. She is an expert family medical specialist who delivers comprehensive primary care and committed to providing excellent health care to improve patients' health. Dr. Wallace is the medical director of SBI of Illinois, and he has provided care to citizens in the South Suburbs for over 27 years, with 25 of those being at Ingalls Memorial Hospital. And he led to the creation of the Ingalls Care Network. Wendell is a behavioral analyst at Prairie Services. Prairie is a not-for-profit behavioral health care provider, providing outpatient counseling and mental health services throughout the community. So we thank everybody today for being here, and we will get it kicked off right away with our first question, which we hope will dive right in and start the conversation. So how does income inequity affect access to care?
My name is Wallace. I practiced medicine out here for 27 years. I'm the medical director for Specialty Physicians of Illinois. I do quality assurance and performance improvement. I'm also the post-acute care network medical director for Franciscan, dealing with the nursing homes. Let me just say that, our system, our economic system out here, it's a very difficult situation that impacts patients unfairly. What you have here, you talk about health inequities in the greater society, but then we talk about healthcare itself. You have your providers, you have the insurance companies, okay? And what you have here is you have only a finite amount of income to provide care. Everyone in here, in some way, shape, or form, we are subsidizing healthcare through our, taxes, however you want to look at it, okay? So, what you have is, our hospitals, I'll just start from the beginning. I've been out here for 27 years. When I first came out here, all the hospitals were pretty much independent, right? And the hospital, if you're going to be independent, you have to be self-sustaining financially. Then over time, most of the hospitals have had to find a partner, a corporate partner. You have UC Ingalls, get Aurora Health. You know, and they're all trying to do the best they can, but the reimbursement from the insurance companies is lagging. You know, basically, if you're a hospital, you have 4 types of patients that come to your door and you treat everybody. So you have those patients with no insurance, you have Medicaid, you have commercial, you have Medicare, okay? So, obviously, you know, 2 out of 3, unfortunately, don't cover the cost of care for patients. You know, patients are older, patients are more complex. Okay, so the amount of money that the hospital is spending on caring for those patients is increasing, but the reimbursement is lagging behind it, okay? Then also you have doctors' offices. Doctors' offices used to be, you know, a doctor wasn't an employee, a doctor was independent. You know, you want your doctor working for you. But you have a lot of things going on in the medical world where, say for example, I'm taking care of a patient, you can relate to this too. I write a specific order for a medication or a test, well, it has to be approved. It has to be approved by the insurance company, okay? And then also the amount of documentation we have to do has resulted in us actually spending less time with the patient. Probably many of you have had experience where you go to the doctor's office and the doctor is like typing on the computer the whole time. They have to do all this documentation, which is onerous. I had a patient come to me not too long ago, a new patient. He says to me, Dr. Wallace, thank you for looking at me. You know, I think that's very telling when someone comes to you and says, you just a basic thing. I'm talking to you and I'm not looking at you. So I think what we have to look at is the reimbursement and how we can increase reimbursement to the people who are providing the care. You know, because patients suffer when, you know, they have blocks, they can't get medications they need. For example, say diabetes. Diabetes is a $500 billion cost to this country, okay? $500 billion. Diabetes is a preventable disease, but it's extremely high in the south suburbs. We have some of the highest complications of diabetes in the entire state of Illinois in this area. And you know, you have to look at that. There's like new products, like, you know, people with diabetes, they have to prick their finger, okay? That's unpleasant. Now we have new products here where a person can put a simple device on their arm, scan it, and I found that it really helps people to better control their diabetes. But yet, trying to get the insurance companies to pay for it is an issue. Paul.
Thank you, Dr. Wallace. And I asked Dr. Turakhia the same question. You know, financial means is a barrier to access to care. You either have the means, you have the insurance, and you don't. Obviously, Dr. Wallace is making a point. It's a barrier. How would you define access to care in your world or expand upon what Dr. Wallace is talking about?
Yeah, I mean, it's 100% a barrier, and I agree with everything Dr. Wallace was saying. You know, it's not, it doesn't, we don't need like scientific kind of studies and guidelines for me to tell you that a patient with no health insurance has poor outcomes, health outcomes, right? So children that don't have insurance are not going to get access to the vaccinations they need or the care they need when they have sick visits. Same with adults. In terms of medications, like Dr. Wallace was saying, diabetes, for example, insulin is very expensive, and out-of-pocket costs are several hundreds of dollars per month. You know, you can't afford that. People can't afford that. Plus, you have to make sure insulin stays in the refrigerator. What if you don't have a refrigerator at home? Or what if it's not working? Or what if your heat's broken? Whatever the case may be, a lot of things kind of go into this. And if you don't have the financial means to pay for insurance or even to just kind of have working refrigerator, AC units, things like that at home, these are the things that you can't get access to care. You have uncontrolled diabetes, you end up getting complications from that, you end up going to the hospital, having this large bill, staying in the hospital several days, you know, like Dr. Wallace was saying, who's kind of covering those costs. So those things to think about. Lack of insurance is a huge one. I also think that I've seen it quite a bit in this area, but you know, language is also huge, and so you know, we kind of take that for granted sometimes, but patients where English is not their primary language, it's very hard for them to get access to care. It's very hard to sign up for Medicare. These are things that we kind of, again, take for granted if English is your first language, but if it's not, you have multiple kind of barriers to kind of get the access to care that you need, for sure.
Mr. Brown, how does this impact the mental health?
Well, I'm going to come from a whole different perspective, more of the if you, for example, if you have someone that is with their children, and I'm sure that some of the colleagues in the room can attest to this, and they're living in a van, and she's living there with 3 children, and they need medical attention. The depression, the anxiety, all of those environmental stressors can contribute to not only the physical health, but the mental health. And we have to address that issue income-wise, knowing that in 2022, there are individuals that are sleeping under bridges, sleeping in their vans, whole families that don't have access to proper medical care. And that is a mental strain on anyone. And many of us go on our day-to-day, daily way and not even address those issues because we don't want to be associated with those that are quote-unquote undesirables. And so there have to, as Dr. Wallace said, there's only a finite amount of money that will address these problems. I don't know what the solution will be, but I do know from on a daily basis, we have to challenge each other in the area of mental health. There's not enough emphasis being placed on mental health. And it's something that does not discriminate, and it's something that we all experience at one time or another.
Could you comment your observations on the challenge about access to health care? What are you seeing on a macro level? Are things improving? Are things static? Are things deteriorating? Are you seeing any help from the state? Just some general comments about just the state of access to care and whether you see any hope, any things that are improving or staying the same.
So, as a physician, right now we have a 90,000 deficit in physicians in this country. By 2025, it's expected to be 130,000. They started many years ago these hospitalist programs where when you go to the doctor, when you go to the hospital, a different doctor takes care of you. Now, I'm an internal medicine doctor. The internal medicine residents that we train, we have like 140 slots at Olympia Fields. Well, most of them want to be hospitalists or they want to go to a subspecialty. They're not wanting to go work in the community. Now, a lot of it has to do with educational debt. I know a lot of people don't have a lot of sympathy for doctors being in debt. But the fact of the matter is that many of these people are $400,000, $500,000 in debt. Now, I'm from Illinois. I went to Southern Illinois University. The state gave me a scholarship to pay for my schooling, okay? Also, I think a lot of people don't know this, is that when I went through, when I had my loans, okay, the law was no one could charge you interest, okay, until you were no longer in school. So I went 9 years with no interest on my loans, okay? Ronald Reagan changed that. We need to fix that. Not just for medical doctors, for teachers, for nurses, anyone. It's wrong to take a college student and start tacking on interest when they're trying to better themselves. Okay? That's income inequality 101. Okay? So, we've got to do more to get physicians to go into primary care and work in the community because that physician is going to be your steward. They're going to be your partner for your health, to give you the best health benefits, the best health outcomes, to diagnose disease, to keep you healthy. And the other thing about mental health is that, I have a whole deck in my office of psychologists. It is extremely hard to get a psychologist now. They are so busy. So we really need to start getting more people into these mental health careers. We recently did a survey where our membership especially the younger people. The number one diagnosis for people under 22 is anxiety and depression.
Absolutely. Thank you. Dr. Turakhia.
I just wanted to piggyback about what Mr. Brown was saying, Dr. Wallace, about mental health. Not only is it very hard for patients to get in to see a therapist, to see a psychologist, to see a psychiatrist, but these patients, we're assuming, have the means to pay for that. So either their insurance has behavioral health coverage, which is usually certain commercial insurances, not all. But if you have a patient, that has Medicaid or no insurance, has severe anxiety and depression, which, to be honest, Paul, you were saying since the pandemic, anxiety and depression has gone up through the roof, but insurance coverage is not matching that. And so when you have patients that are suffering from anxiety and depression, how are we asking them to pay $200 out of pocket for a 1-hour visit with a psychologist? Who has that? And so if their insurance doesn't have that coverage, it's really hard for these patients to be seen. They're trying to kind of get seen with the primary care physicians, again, spend $150, $200 out of pocket to see us, just to have maybe 15 minutes of our time, since we're, seeing patients back to back, to just kind of talk a little bit about what's going on, maybe start medication, but it's something that needs to, I think, improve is for sure the behavioral health coverage in terms of the insurance companies.
Absolutely, and to add to that, people are exhausted. People are working 2 and 3 jobs. People are looking for resources. We have people that are living longer. We have the generation that is taking care of the older generation, and we have the generation that's also taking care of the younger generation at the same time, and so we're doubling our household duties. People have now gotten to the point where as they just give up and they just say, okay, that's it, I can't handle it anymore. The major depression, the anxiety, the suicide rate is astronomical. That 988 suicide number, I would very well recommend you to use that, because I see across the room a lot of outreach and engagement workers, and boots on the ground, suicide is one of our major crises, and it does not discriminate, and each and every person probably in this room at one time or another, depending on the circumstances, have contemplated it. But if you're in trouble, dial that 988 number. We also have a mobile crisis unit at Grand Prairie Services that you can dial, and they'll come out and they'll assist you. Mental health is probably our next pandemic, I would say, because and again, it does not discriminate, and we don't have enough staff out here in the workforce or the workplace, or we have not trained enough staff to deal with the variations of mental health that has plagued us now. And so we need to take this much more seriously than we have.
Thank you. If there's other questions that you have in the audience, please let me know. Yes, sir.
Apostle Carl White Jr., I hear you talking about a bichotomy, but man is a trichotomy. You cannot leave out the spiritual when you're talking about the mental and the physical. Our churches are suffering really bad because of the pandemic. A lot of people didn't come, left out. The next generation knows no foundation of God. They're on video game. They see shoot 'em, and that's a game to them. And so they shoot 'em in reality. But if you're going to fund everything else, the church is only funded through tithes and offerings. So we need to have more of you, and all of us are very smart people, but you got to be smart enough to know that you are a trichotomy, mind, body, and spirit. When your spirit is not being fed, your mind is wrestling. And the one that feeds the most, whether your flesh or your spirit, that's who you turn to. And whatever religion or whatever you do, if your spirit man is not fed, your mind and your flesh are going to go awry.
So the question is, spiritual health, mental health, physical health, the point is, how do you address access to care in a spiritual sense, in addition to the physical sense?
Well, in our treatment plans, here at Grand Prairie Services, we actually ask the consumer, because we don't call them clients, the consumer, whether or not they want a level of spirituality in their treatment plan, along with all of the rest of the treatment that they receive. And 85 to 90% of them say yes. So they're very much aware of the level of spirituality that they need, along with the physical and emotional and the mental. For years, the church have not addressed the mental aspect of that. I commend Apostle White for addressing that at the Southland meeting and with his parishioners, because it has been the elephant in the room. How do we address the mental health issues? What do we do in regard to signs and symptoms? We have a youth mental health as well as a adult mental health first aid class that we give at Grand Prairie Services, and it's available to anyone or any organization that needs it, where we have instructors so that you can identify the signs, the symptoms, and all of those things relating to whether or not someone's in trouble with mental health. And so I would encourage you to take advantage of that. I think Liz Murphy has a table. We have a table back there with all the information. And so I'm not going to take up a lot of time, but take advantage of it.
Thank you. Dr. Turakhia, Dr. Wallace, comments on spiritual care?
Well, I mean, certainly I understand exactly what Apostle White said. We try to encourage faith. We are a faith-based organization at Franciscan, and we understand how the Spirit needs to be fed. But we also have to look at the greater society. There's a lot of things that we talk about, church, going to church on Sunday. I was raised, when I went to church every Sunday. I went to a highly religious high school in the South. And, it has made a huge impact in my life, okay, in terms of learning, about the Bible and how you treat people. And we reflect that in our Franciscan values. But, there's so much influences, negative influences on people. The internet, I thought was a great thing, but the internet has been turned into a negative cesspool of just bad thoughts. You look at the politics, you look at all the other things that our young people are exposed to, and it leads them down the wrong path. And you have to kind of go to church, right? But all this stuff on the internet is right there on your cell phone. We're addicted to our cell phones. One of the things we talk about is healthy living. There's basically 4 things you have to do to have a healthy life. It's your diet, healthy diet, okay? But how can you have a healthy diet when we promote, food that's not good for you? We promote processed food. I mean, where my office is in Madison, I hate to say it, but I'm surrounded. I'm surrounded by, bad, unhealthy food outlets, okay? And people are stressed. The food, when you eat it, it makes you feel a sense of euphoria. It's temporary, but it also causes you, over time, to develop diabetes, okay? Diabetes is a preventable disease, but we have to put things in society to help people eat healthy. Number 2 is regular exercise. Because of the work, the computer. My parents never brought work home, right? We're all slaves to our computers. You come home at night, I know you come home at night, you're progress, right? So with me, I'm working 7 days a week, basically, doing documentation. A lot. If you're a social worker, if you're a nurse, you go to the hospital. What do you see the nurses doing? They're all pushing computers down the hallway. Because the documentation, I hate to say it, is becoming more important than taking care of the patient. And that's a fundamental problem. Okay? And, I'm gonna just end with this, okay? We can't have insurance companies making millions of dollars in profit when people can't get care. Why are you paying for your drugs? Why can't you get the care that you deserve? While they're making, buying a goddamn yacht, excuse me, and you can't get basic care. It's unacceptable, and we need to put a stop to it.
Thank you, Doctor. Other questions from the audience? We've touched on the financial challenges. We've touched on providers. We've touched on homelessness, which we will address in one of our panels. Other barriers that you see that are important to talk about when we discuss access to care. Let's throw transportation out. How much of a barrier is transportation as it relates to access? Would you care to comment?
Transportation is huge. A lot of our elderly patients, I know that I see, don't drive. I'm sure it's the same with you, Dr. Wallace, and they don't have family or friends that can just take off half a day of work, right? That's income that's not coming in to pay for health insurance, to pay for their children, to pay for food on the table, to come bring their grandmother for a visit that's going to take a couple hours, then they have to take her back. So transportation is huge. I know there are services we have in the Southland area, again, based on what insurance you have, that can kind of help to provide transportation, but it really is exactly what Dr. Wallace said. It's just really unfair. It's very unfortunate that you, as a patient, based on what you can afford, what insurance you have, or no insurance, will literally determine, can we pick you up and provide services? Can you pay for your insulin? Do you have a refrigerator that can kind of keep it cold? Can you come for your follow-up visits? Can you go to the specialist visits? It's very unfortunate. We have a lot of patients we see that are uninsured, or barely kind of making ends meet, and then we kind of wonder why our hospitalization rates are so high, why the complications for heart failure are so high, these diabetes complications are so high. These are preventable things, but if you don't have the access to care, if you don't have the income or transportation to do this, you're going to end up in the ER and in the hospital, and then millions of dollars, billions of dollars in debt with these just kind of hospitalization rates.
To piggyback off of what she said in regard to transportation, we spend, I know, at least in our agency, numerous hours trying to even get the transportation companies that are assigned to pick the patient up. Sometimes they won't even show up at all. Another time, by the time they get there to the doctor's appointment, the doctor has seen numerous other patients, and it's just, as Dr. Wallace said, that it's just to the point that transportation is one of the major problems that a lot of our clients have. We spend a lot of time arranging for them to have bus cards, arranging for them to sometimes gas. If they make it to the clinic, then a lot of times we have to give them gas money to get back home. So it is very crucial with transportation that we address that issue, because of the fact that without that, they won't even show up.
I'm just going to say this. We need more public transportation for everyone, okay? Public transportation, you know what it does? It makes you walk. It makes you walk, it makes you exercise. If you have exercise that's just part of your daily life, you'll tend to be healthier, have a lower blood pressure, be less risk for diabetes. Also, it economically empowers you. If you're looking for a job, you have to be able to get there. So we really need to invest a lot more money in our transportation infrastructure. And yes, I have a lot of patients who have difficulties making it to my office. Also, I agree with what you said 100%. And it affects their care, and it does result in unneeded and preventable hospitalizations.
Thank you very much. Question from the audience, please.
All right, thank you so much, panelists. You are absolutely phenomenal. You're giving us great information. And as we all know, knowledge is power. It's said that people perish, but the truth is people are destroyed for the lack of knowledge. So what I'd like to ask, and there are several points in this. One, we're talking about transportation, we're talking about the finances, but also, and we're talking about the mental health and how do people get access to all of this information, which is a major component here. But in a world where we are talking about social influences, virtual reality, the metaverse, and all of these places, how does the healthcare industry fit into all of this as we're moving into new dynamics for the 21st century? With COVID, we had a very time of, and we still are, where there have been tragedies, there have been challenges, but it forced us into the 21st century. So now, how do we handle this when we live in a virtual reality life?
Thank you.
Well, telehealth that I've been introduced to and that we use, I don't know if the doctors here are more, I know they would rather in person so that they can actually see. But telehealth is in regard to mental health and psychiatry and being able to reach the masses have been very, I would say, 50-50 as far as I'm concerned. But it has allowed them to, when they can't make their appointments, for at least the doctor to make contact with them. But for me, we want to be very careful with those telehealth and not the inpatient. Some things cannot be replaced only for I would say a minimal amount of seasons. Some things have to be, when it comes to people, it has to be in person. And I understand technology is, but as Dr. Wallace had stated before, sometimes we can become a slave to that, and then we don't even recognize the person anymore because we're so busy seeing them on a screen or not having that person-to-person contact that it becomes, we become robots, I'll say that, instead of having a person-to-person relationship.
Thank you. Dr. Turakhia, Dr. Wallace, addressing the challenge of the healthcare industry responding to the overwhelming avalanche of information and technology and the stress that's causing in society.
Well, first, I just want to say for virtual visits, Franciscan has a very advanced platform. We use virtual visits all the time for our patients. Any physician, any nurse practitioner, any PA, a patient can easily schedule a virtual visit with the doctor. We also have an advanced remote monitoring system for those patients that are sicker, where we monitor their vital signs, their weights at home. And, we have a very advanced congestive heart failure program where, they will send me, live chat. We have like a live chat, so if I know my patient's gaining weight, we need to give them more adjusted meds, get blood drawn. So that's really one way we're dealing with the virtual platform. I'm sure, I know UC has the Epic segment we have, so you have you have your whole chart there, and that chart contains all different types of components. Like when I see a patient, it tells me if there's gaps in care. So I know like if you need immunizations, if you're due for a screening test, if you got it done, like your COVID, if you go and get your COVID vaccine, I can see where you've had it done. If you complete it, if you need something done for that, if you're missing certain immunizations. So there's a lot of technology that we use to proactively manage patients.
Yeah, just to piggyback what Dr. Wallace was saying, I feel actually that telehealth or the pandemic kind of forced us, like you were saying, into kind of incorporating telehealth a lot faster, at least from the provider standpoint, which I have loved, because if, especially with certain patients that, again, we talked about transportation. If they don't have access to transportation, at least they can log on. I can see them, and at least I can get the conversation going. Are you up to date with your screening? Do you need a colonoscopy? Why don't you come into the office when you get a day off of work, or someone can bring you? So I feel that telehealth has really helped a lot from the provider standpoint, for sure, and just being able to at least see the patient check in. Like Dr. Wallace was saying, there's a lot of kind of advancements that have been made, and the pandemic has forced us into that. Because to be honest, when they have barriers to language, if their sister's at home that speaks English, she can kind of watch over the visit while I'm talking to the patient to kind of help with that. So it does help a lot.
Thank you. Thank you all to our panelists. We only have a couple of minutes left for this session. Any concluding remarks that any of you may have on this incredibly challenging topic, access to health care as a social determinant of health?
I would just like to thank everyone for attending today. Your doctors, your hospital, your nurses, they're trying to do the best we can to take care of people, but we need to really try to remove those barriers. We need to look at our greater society, and we need to address things that are promoting illness, because no matter how hard we work, if you have a situation, an environment that promotes illness, well, it's hard to counteract that. We need just the opposite. We need to have more of an environment that promotes health, healthy living, spiritual, diet, stress reduction, regular exercise. We need to embrace that as a society, and we need to really promote that, through social media, conversations, churches. Any way we can, we need to emphasize, we need to love each other, and we say, look, I love you, I want you to live a healthy life, I want you to be not in pain, I want you to be free from stress. We really want to focus on that, and we need, backing from government, from any way we can to try and prevent that, because, we're all paying the cost. It's a tremendous cost, and that money, if we keep people healthy, then we can use that for other things. But right now, we're using it, the horse has left the barn, and we're spending it trying to get that horse back in the barn. We got to keep the horse in the barn.
Just thank you all for being here and for the great questions. I really completely agree with Dr. Wallace was saying. We really need to focus on the prevention for all the policymakers or those that influence that. There's many barriers that can be lifted with increased funding, transportation, getting more access for certain things with insurance companies. That kind of stuff can really help a patient. It helps the whole society as a whole. It really prevents a lot of costs and kind of this burden that we're now feeling. Everything that happened with COVID, kind of trying to play catch up now, trying to get people back into seeing their physicians, catch up with 3 years of unhealthy, to be honest, living and not wellness. And I think that if we just have that in place, like Dr. Wallace said, to begin with as a society, we wouldn't really feel this kind of catch up phase that now we're in.
I would like to also thank everyone for coming. This is an issue that we tend to kind of put aside, but it's very important. I do agree also with prevention that people are not just numbers. I like the personal touch that Dr. Wallace has said in regard to loving yourself and one another. We have to get back to that. We have a whole different population of this next generation. And if we don't do something about it now, they are going to spiral out of control. And so right now we have a chance to make a definite impact in our health care for these doctors and mental health especially, and we need to place more emphasis. And if you're in trouble or you know someone in trouble, please contact that suicide hotline at 988, because it is vitally important. People have a negative stigma in regard to mental health, but mental health touches each and every one of our families in this room.
Thank you. At this time, I'd like to call forward Terry Winfrey to wrap up our first panel and transition into my co-chair, Celeste, based from Superior Animal.
Thank you. Thank you, everyone. Can we have a big round of applause for